Hi friends, a very warm welcome to you all. Today we'll be talking about neuromonitoring in the series of critical care multiple choice questions. So why is neuromonitoring very important? A large number of patients who are coming to our critical care units nowadays are belonging to neurocritical care subset, or they may have a traumatic brain injury or some stroke. So today we'll be talking about how do you monitor these patients, what are the newer modalities, and we will be discussing about them through a series of multiple choice questions. So, monitoring the brain after traumatic brain injury, subarachnoid hemorrhage, and neurosurgery plays a crucial role in guiding management, optimizing cerebral function, and prevention of secondary brain injury. So, the last part is very important. The idea is to prevent the secondary brain injury. And that is why, to prevent this, we have to be very careful in monitoring the cerebral function and we have to alert ourselves as soon as possible. And all the modalities aim for prevention of secondary brain injury while maintaining adequate cerebral function. So the very basics, what is the normal range of ICP in a supine healthy adult? The correct answer is 3 to 15 millimeters of mercury. So cerebral spinal fluid acts as a dynamic pressure system, and the pressure for CSF can be measured directly from the lateral ventricle via a lumbar puncture, a lumbar drain, or a intraparenchymal sensor. And the intracranial pressure is physiological value is around 10 to 15 millimeters of mercury in adults, and higher values corresponds to intracranial hypertension. So important thing is to know the Monroe-Kellie Doctrine. This can even come as a multiple choice question by itself. This tells you that the cranial vault is a fixed volume, and this is made up of brain tissue, cerebral spinal fluid, and the blood. And since all the three components are in a particular ratio and the whole cranial vault is fixed, any increase in one component must be compensated by a decrease in other to maintain a normal ICP. If this doesn't happen, the intracranial pressure increases. And critically ill patients, even a modest increase above baseline can impair cerebral perfusion pressure. And what is cerebral perfusion pressure? It is the mean arterial pressure minus the intracranial pressure. And when the cerebral perfusion pressure is impaired or is decreased, this risks ischemia. So this is how, if you look at the brain volume is 80% parenchyma. Between arterial and venous blood, it is 10%, and CSF volume is 10%. So when you plot the volume against the pressure and look at the compliance, the normal state of ICP, which is the leftmost thing, tells us that there is high compliance. But if there is some intercalaneous mass, edema, some bleed, and if it increases gradually in size, we realize that the compliance decreases, the ICP increases, the cerebral perfusion pressure decreases, and the chances of brain herniation in case of significantly elevated intracranial pressure increases. So we have to be very careful. So if you just remember this diagram 80, 10, 10 and the compliance curve, you'll be able to identify the Monroe-Kellie doctrine. Now, how do you measure the intracranial pressure? So which method is considered the gold standard for measuring ICP? This multiple choice question has come many times at many places. So the correct answer is intraventricular catheter. So monitoring of ICP is useful in a range of pathologies, including traumatic brain injury, hydrocephalus, stroke, and encephalopathy. And it can be measured using devices inserted into a ventricle, the brain parenchyma, the subdural or the subarachnoid space. The intraventricular catheter is a gold standard method, and this provides a global measurement of intracranial pressure, but it allows two more things. First is you can drain the CSF therapeutically, thereby decreasing the CSF component of the volume. And even in cases of infection, you can administer intrathecal drugs. So it is placed in the lateral ventricle through a burr hole, usually at the Cocker's point. And the advantages include high accuracy, you can calibrate it, and ability to drain the CSF for ICP control or taking of samples. The disadvantages obviously is infection, hemorrhage, and technical difficulties. So Cocker's point is a specific location on the skull used as a landmark for inserting an intraventricular catheter, typically for draining either the CSF or monitoring the ICP, and it's located 1 to 2 centimeters anterior to the coronal suture, 2.5 to 3 centimeters lateral to the midline, and 11 centimeter posterior to the nasion. So just remember the Cocker's point and the intraventricular catheter are correlated. That will be good enough for multiple choice questions. And why is this point chosen? So the landmark has been chosen to minimize the risk of damaging important brain structures like the motor cortex or the sagittal sinus. Now this is how you measure the ICP through the intraventricular catheter.
Okay, I've found this on the web for I to the interventricular.
And you zero it to the external auditory meatus. So the idea is to zero it at the level of foramen of Monroe, but the external auditory meatus is the external landmark that you zero it when the patient is supine. So after you zero it, thereby you can measure the ICP. And as I told you, we can, by measuring the ICP, we can actually calculate the cerebral perfusion pressure, since we all measure the mean arterial pressure in all the critical care patients. So according to Brain Trauma Foundation guidelines, at what sustained ICP should treatment be initiated in severe TBI? The choice are more than 15, more than 22, more than 25, and more than 30. The correct answer is more than 22. So treating ICP above 22 millimeters of mercury is recommended because values above this are associated with increased mortality, and prolonged elevations compromise the cerebral perfusion pressure and increase the mortality. Now, how do you decrease the ICP? First are simple maneuvers like head elevation, trying not to turn the head to one side in extreme. Using hyperosmolar therapies. If you have an intraventricular drain, you can do some bit of CSF drainage. And as a method of last resort, you can do controlled hyperventilation to and move on the patient to the surgery to have a decompressive craniectomy. So as I told you, we know how to calculate the cerebral perfusion pressure. So patient has a mean arterial pressure of 85 and an ICP of 20. What is the cerebral perfusion pressure? A very simple MCQ and very scoring one. The correct answer is 65. That is mean arterial pressure minus the ICP. So maintaining adequate cerebral perfusion pressure is critical to ensure sufficient cerebral blood flow and oxygen delivery. And usually it is maintained in the range of 60 to 70 millimeters of mercury in the normal adult neurocritical care patients. Too low cerebral perfusion pressure risks ischemia, and too high cerebral perfusion pressure may increase cerebral edema and hemorrhage risk. Now, I've told you the correct answer for this, but this can even come to ask you the cerebral perfusion pressure range. So either you can be asked to calculate the cerebral perfusion pressure, or you can be asked what is the range of cerebral perfusion pressure in which you have to maintain the patient in an optimized manner so that you prevent ischemia as well as hyperemia. So the range is between 60 to 70 millimeters of mercury. So now we know about how to measure the intracranial pressure. While you measure the intracranial pressure, how to calculate the cerebral perfusion pressure. Avoid intracranial pressure of more than 22. Keep the cerebral perfusion pressure in the range of 60 to 70. Now we look at the ICP waveforms. A 36-year-old male with severe traumatic brain injury is on an external ventricular drain monitoring. The ICP waveform shows the tall P2 peak higher than P1 with P3 barely visible. Which of the following best explains this finding? To know the answer to this question, we have to know what is P1, what is P2, and what is P3, and what are the normal ICP waveform looks like. The correct answer is decreased intracranial compliance, and we'll be seeing, just remember, a tall P2 peak higher than P1 tells us about decreased intracranial compliance. So the ICP waveform typically has three components. P1, that is a percussion wave, that is the arterial pulsation transmitted via choroid plexus and reflects the systolic upstroke of the arterial wave. Then P2 is called tidal wave, that is the compliance wave. It reflects the brain's ability to accommodate arterial pulsations without significant pressure rise. And P3 is dichrotic wave. It tells us about the venous outflow component coinciding with the closure of the aortic valve. So just remember P1, P2, P3, percussion wave, tidal wave, and dichrotic wave. And P2 is the compliance wave. Just remember this much at least.